Thank you, everybody. I'm Debbie Kennedy. My title's Head of Clinical Programmes for NHS England, and I'm your chair for today, and Karen's going to assist me. So,
able assistant.
Yeah, so we're delighted that we've got Dr. Richard Russell on the call today. If you remember the last meeting, some of you might not because you weren't here, but the last meeting we started to think about winter and winter planning, and we thought it'd be really interesting to hear Richard's perspectives on, what we might expect. We're not going to hold you to it, Richard, but what we might expect over winter. So I think we're going to do this as a sort of question and answer session. So, Karen, if you could go to the next slide, and I'll start the question and answer session. So, thanks, Richard. I just wondered first if you could introduce yourself and say who you were and what your background is. Thank you.
Yeah, sure. I'm Richard Russell. I'm a chest physician. I've been a chest physician since 2003 as a consultant. My NHS job is based in Leamington, New Forest Hospital, and I run here the Community Respiratory Service in Hampshire. I'm also the clinical director of respiratory now for NHS South East England, and work therefore looking after all the counties around the south of United Kingdom, and also I'm the lead for Hampshire Isle of Wight as well. Other roles, I'm a senior clinical researcher at the University of Oxford with a kind of interest in primary care crossover research in airways disease. So COPD is my main research interest and output. So that's what I do, and I'm the editor of the International Journal of COPD. So kind of quite busy, but find time to enjoy everything I do, which is good. And that's a bad thing because I tend to pick up too many sticks and run with them, but that's me.
Thank you, Richard. So, what do you think might be some of the challenges facing us, not particularly with the homeless yet, but just thinking about this coming winter?
Yeah, I think it's a really difficult one this winter. I think a couple of things. One is we make assumptions and assume because we've got a COVID pandemic on, things are going to be different. Do you know what? There's no reason why they should be different. And actually, particularly as we're now relaxing all of the social control, shall we say, of COVID and lockdown, there is no reason why we're not going to have a problem. If I may really quickly share one screen for you to show you how different it has been. So this data I'm just going to show you now, which you can probably see that graph, can you?
Yes.
Yeah, okay, that graph is a graph of respiratory infections in Australia, okay, over the last 6 years, okay? And the red line is the line for this year, and the green dotted line is the line for last year. So those are COVID years. Remember, they have their winter peak in the summer, not in the autumn winter. And you can see all of the other years are way up high, but the last year and the year before were actually really low, and that's because of COVID. It's not because of COVID stopping these infections. It's because of the social behaviours and the changes that we made in our lives that have stopped those infections. So respiratory illness in the winter is caused by transmissible infection, socially transmissible infection, and they are viruses. Okay, and as you probably also aware, respiratory-wise, 85% of our activity disappeared in April last year, and it's not really come back because people were socially isolating, wearing masks and washing their hands. This winter is very unpredictable, Debbie, and I think one of the difficult things is we are going to have the viruses, we're going to have COVID, and what happens completely depends upon people's behaviours. COVID, for example, is entirely responsive to people's behaviour. The football tournament in the summer caused the spike of COVID that we've just seen. There's no question about that. It was up, it was down really, really quickly. What is going to happen when the schools go back? No big surprise, we're going to have another outbreak, just like we did last year of COVID, but also, and this is what people are worried about, the response of respiratory syncytial virus, influenza virus, all the other respiratory viruses that we actually see, the adenoviruses. So there is an unknown to it, but I think we need to prepare that it's going to be the same as normal if we don't maintain a degree of social awareness and responsibility and behavioural change, and that's really difficult, because the last thing this country wants to do, last thing any country wants to do after a pandemic lockdown, is then to be told, do you know what, you should still be wearing masks, you should still be staying away from people, and you should still be washing your hands. But you know what, we probably should. So we now know how to solve the winter virus crises, but is the medicine too hard for us to swallow? You're on mute, Debbie.
I'm on mute. Typical. I mean, we are worried because nationally, the uptake of the second vaccination, COVID, in the homeless population is not as high as we'd hoped it would be by now.
Sure.
The first vaccination, is the uptake rate's quite high, but the second vaccination, and we've got some questions later on to try and explore why people think that is. But I guess the risk, how much protection would the first vaccination give against something like long COVID?
So there's several issues here. Really, very, very important to say. I think a lot of the things the problem with homeless people, the problem with hard to reach populations, or seldomly looked at populations, is that very nature, that the data is not there to support any kind of meaningful conclusions, because we just don't have it, because we're really bad at collecting it, and it's difficult to collect. That's no excuse, though. To give you the facts on the vaccination, so there's no question, if you've been double vaccinated, you can still get COVID, but it will be milder. 95% of the patients who are dying at the moment in hospital have not been vaccinated. Okay, that means unfortunately they're younger and less, in fact, effectively less. With less comorbidities and risk factors to start with. But the vaccine is in that sense protective, not against necessarily illness, but very much against rapid deterioration and dying. So that's a good thing. The two vaccinations lead to about 90-95% protection, single vaccination somewhere between 50 and 70%. Now, the worry about that, not worry about that, but the worry about it is over time, is that the vaccine will slowly reduce in efficacy over time. So the whole point of booster vaccines comes in, which is what people are thinking about. I think it's particularly pertinent, obviously, to vulnerable populations, and homeless people are extremely vulnerable, both because of underlying conditions very often, obviously living conditions and also living together. So we know, for example, that hostels and that kind of accommodation are extremely high risk for outbreaks of COVID, as well as obviously other viral infections. And so pushing vaccination will be really important to prevent significant illness and hospital admission and mortality. The other treatment, just to throw in, that's actually effective when given as soon as you get symptoms of COVID, are inhaled steroids, so asthma-like medication. And there's been two big studies, the STOIC study and the Principle study, both have reported that giving people inhaled steroids early actually reduces symptoms, shortens duration of illness, and prevents deterioration leading to admission to hospital. So that's a good thing as well. We're yet to get full approval for that, but it's been approved by the chief medical officer in a controlled way. But again, from a homeless perspective, that's obviously difficult because access to healthcare is poor.
Yeah, I mean, we don't have data in the southeast on access to, how many homeless people are registered with primary care physicians. London does have data, and they think that 23% are not registered. So, I mean, that's some good news there, I suppose. I suppose it's about how able are those GPs to respond to the needs of homeless. And I don't even know where you would get inhaled steroids from, but how able are they to respond when they're doing all the other things like booster vaccinations, etc.?
Absolutely, and the vaccination program is probably more important. But the issue, absolutely, with it is getting the message out there. There are lots of inhalers and stuff you can give, but people have got to know how to do it, and it does have to be done with on a one-to-one. That's the kind of rules at the moment. So it's an extra thing just to throw in, but it's a thought, but it's safe and it's effective. But the key absolutely is getting people vaccinated, which is. It protects them against COVID, not against all the other viruses. And again, getting people to be sensible with their behaviour will be absolutely critical.
Thank you. Just another question I wanted to ask, because I know it's an interest area of yours, about deprived populations. Is respiratory illness a disease of deprivation?
Yeah, 100%. So actually, if you look at respiratory physicians, don't do much private practice. That's the truth, because we don't have populations of people that are either insured or rich. We do other stuff. Yeah, absolutely. If you think about respiratory disease, the one that jumps into your minds of the history of respiratory disease, and the British Thoracic Society began as the British Tuberculosis Society. So tuberculosis is the archetypal, primary respiratory infection, and actually it's exactly. And we know that levels of tuberculosis in this country right now go up and down as access to support, income support, etc., goes up and down with different governments. There's been very clear links and associations with the attitude of the government to social care and support and tuberculosis levels. Obviously, they're very low level compared with what it was in the pre-antibiotic era, but it's absolutely there. And the same things exist for all of these other things, whether it's relative malnutrition, cramped housing, poor housing situations. And obviously, as I mentioned, underlying conditions, all of and smoking obviously being the other massive issue with respiratory disease. So we know that goes hand in hand with all measures of deprivation.
Thank you, Richard. I mean, one of the things we were talking about just this morning, actually, is under vaccination in mental health populations. So when somebody is admitted to a mental health facility, if they're not vaccinated, then could they be offered the vaccination in that facility? Is there anything that you're aware of that's happening to sort of maximise every contact counts, I suppose?
Yeah, I think that's a really good point. Well, I work, my home trust is Southern Health, and Southern Health is one of the biggest psychiatry trusts in the country. And so I'm very involved with various things going on in Southern, and I'm not aware that we do this, and we need to be. It's because of the structure of the vaccination programs has been obviously through primary care, which is a hugely successful structure and works for the vast majority of the population, but not for those people who are not very well engaged with their primary care services, as you've already said. So it's something which I think is a huge potential easy win. It's a potentially quick win. It would be safe and easy to do, and you could obviously set up, for example, a vaccination slot once or twice a week in any place where there are people being seen, particularly with mental health problems. Mental health patients are erratic, again, bounded by the very nature of their problems with their healthcare contacts, and so taking that opportunity is so important. And it's something which I hope I'm not involved in the vaccination strategy, unfortunately. I hope it's being looked at, but actually from all the people on the call, it would be a fantastic thing to push. And I would also say the same for homeless as well. Wherever there are contacts with mental health, where there's drop-in clinics or where there's a mobile clinics set up, etc., that would be an amazing thing to do and would be very, very effective. Because there's no question they do take it up when they're offered it. That's the point. It works. Yeah,
that's our experience of some of the outreach. And if their friends take it or fellow, then the peers take it, then they're more likely to take it. I think I've got through most of my questions. I suppose it's just a little bit about long COVID, really, because I haven't really talked much about that.
Yeah, that's a good question. So you mentioned earlier on about long COVID and vaccination. At the moment, vaccination status has no impact as far as we're aware on long COVID, except it protects you again from getting COVID. So it's maybe 50-60% protective against getting COVID, stops you getting sick. So in that sense, it will protect you against long COVID.
Thanks. It's very interesting. I think that's most of my questions. And I think as well as the mental health settings, there might be an opportunity to provide vaccination in acute settings. So it's about how we make every contact count across all settings. Yeah,
and there's something which we're sadly enough not doing. Hospitals don't do vaccination; they're done in the centres, which is perhaps in some ways frustrating, but it also does perhaps prevent a rather random and scattergun approach to vaccination. So I think they've probably gone for the control rather than the scattergun, which in some ways makes sense. I think just to talk briefly about long COVID. So with long COVID, what we're talking about here because there are elements. So there are three stages of COVID in a way. One is the acute COVID illness, and for most people it's generally mild and not very. It's really not very nice. I had COVID in March last year, really not very nice. The second one is the post-COVID phase. If you've been sick with COVID, you need time to recover, and that's entirely reasonable, whether it's your lungs or other things to get better. And then thirdly is long COVID. Long COVID is happening in some ways as a separate disease, a separate problem after you've had COVID. 6, 8, 12 weeks later, there is a kind of lack of improvement in things like, and the patients present with a variety of symptoms, including breathlessness, brain fog, lethargy. So they're very different. They're not organ specific, and when you look at the medicine, when you look at them medically, you don't find major dysfunction of the kidneys or the lungs or the heart, but the patients themselves have significant symptoms and significant morbidity with this. How are they represented in the homeless population? Do you know what? We really don't know. And there are this is something which needs to be taken forward. And one of our concerns in running long COVID rehab services, and I'm very associated with that in Hampshire, is that we only see the patients we see. So we don't know, for example, how many people out there are in, for example, prisons or in the homeless population, because to be referred into the service, again, you've got to go through primary care practitioners, you've got to be checked out or go through a hospital service, and this is notoriously difficult. So there will be people out there potentially suffering who are not being seen, and actually they shouldn't be afraid at all of encouraging with long COVID services, because we are the services themselves are fantastically responsive and open and friendly and not medical in that sense at all. They're AHP led, with goals of rehabilitation, getting better. Really, that's what it's all about. So it's not medicalizing. So I think it would be very good for people to engage with. The other popular problem with it is much of this is digital. So if you're digitally unable, then that makes things more difficult as well.
Thank you, Richard. That brings me to the end of my questions. I was going to just open it up, if that's all right. Nick,
Sure.
You did have your hand up, but you put it down again.
Thank you. Yes, Richard, with a respiratory hat on, we know that the homeless cohort are 80%, I think, is the latest estimation, smoke. Does this, it's the old enemy, and we all know the multiple dangers with it. Does it, specifically in the context of COVID, make people more vulnerable? Because there's been some very confusing stories about nicotine which muddied the water.
Yeah, sure.
And we work to in some areas to get our cohort using vapes instead of smoking. Well, thank you. That's partially answered.
So that's really important. It's a really good question, Nick, and actually to put it to bed very, very clearly. You're absolutely correct. Smoking is a disaster in that sense, and therefore quitting is very important. We ran a very effective campaign last winter called Quit for COVID across social media, targeting high smoking prevalence areas in the southeast, and getting people stopped was at that time was quite a good message to give. People were very health aware and very health engaged, and still are to a degree, which I think is really important. With regards to COVID and smoking, it is not good. You're absolutely correct. There was some early messages and early signals from research which raised questions about what was coming out, about whether smoking was helpful or not. One of them led to the steroid story, because basically it was observed that people with COPD who've smoked and have got lung disease because of it were relatively protected from ending up in hospital. Well, the answer was it was because of the treatment they were getting, not because of the fact they'd smoked, which hence leads to the steroid story. The message is, if you smoke, you are slightly more likely to get it, not much more, but if you get sick, you are much more likely to be very sick. So again, being trying to avoid that risk, smoking is a helpful, not smoking is a helpful thing. The issue about vapes, I would follow the party line from our quit people at the British Thoracic Society, etc., is that yes, vapes are less harmful than tobacco and less harmful than smoking. They've got less harmful constituents, but they still do cause harm and inflammation, and they definitely can be used and are effective. And I do this as part of getting someone to quit the nicotine addiction. And I think that we're changing. One opportunity we've got with COVID is to change the message around smoking. Smoking is not a social choice. Smoking is not it's an addiction, and we need to see it as such and manage it as such, and being very clear with those messages, which actually really helps people, because people feel empowered when they know they've got that's it's not their fault, and it gets away from the guilt and all the other stuff that goes with smoking, in which my patients have. So I'm taking that line and that message very, very clearly. So vaping, yep, helpful, particularly as a adjunct or as a part of a pathway to quitting.
Thank you.
Thank you. Do we have any other questions for Richard? Is there any in the chat? Let me have a quick look.
And the Andrews there is put to the long COVID spec, so it's a significant spec which we're now working towards. Just to say, I think engaging with long COVID services is going to be very helpful. Long COVID services is about to be enhanced significantly. They've got across the country. We were set up. This is tragic. We were set up with 13 million quid, I think it was, or 7 million pounds across the whole of the country for long COVID, to a great fanfare, and you think this is not enough money. They've now just enhanced that now to by 80 million pounds. So there is a significant amount of money coming to the country, and whether we've got to grow the magic personnel trees to grow the people to actually do this, but there is going to be a significant enhancement in the long COVID services, and one of the absolute criteria or criteria to be judged against will be dealing with inequality and access, so that the homeless fit perfectly into that. And I think we're fooling ourselves in the southeast if we don't think we've got a problem. Of course we've got a problem, but your help in targeting may be very helpful.
Thank you, Richard. Any more questions? Karen's put something about the Tobacco Control Network. Do you want to say something, Karen?
I was just going to flag that we've done an e-cigarette position statement for organisations. So if any of you would like to see a copy of that, then let me know and I will direct you to the link. But it's to enable you to develop sound policies and practice in this area. And so we all say the same thing. We're all saying the same message to avoid this misunderstanding that exists around them. I wanted to ask. Sorry,
Karen. Sorry, Karen. I was just going to quickly add to that. We shied away from getting the people with mental health to quit smoking because the smoking prevalence is massive in there. Do you know what? It works. You can help them. And actually having smoke-free mental hospitals, which I never believed was possible before, we've now managed to do that. So we can do it. We just have to believe.
I was going to ask you, Richard, going back to the conversation around vaccination. So the plan is at the moment that I understand that regions developing the rollout plan for boosters and flu vaccination for the autumn. The flu vaccination letter that was cascaded at the end of July talks about inequalities. The challenge we have in this area, though, is that the homeless community are not included in the criteria for flu vaccination. And so that's going to be a challenge for us and our and colleagues on the call, because we would like to get them vaccinated at the same time as they're having their boosters.
Yeah,
so obviously they fall into one of the priority groups for COVID, but they don't for flu. So any pressure that you can bring to bear in terms of developing that vaccination policy for the region, because London has done it, would be greatly appreciated.
I have an insight. One of my ex-member of my team has moved over to the vaccination service. So I've jotted down as you started. I will email her to find out about that. Absolutely.
Bless you. Thank you very much. Bit of lobbying there. Excuse me.
No worries.
Thank you very much, Karen. Anybody else have any more questions for Richard?
I think we very much appreciate this today from our perspective, and so we very much want to use your expertise, knowledge, and channels to help us to tune our messages and to get the messages out and to make practical differences. Just to explain what the setup we have Southeast Respiratory team. I've got a team of 5 or 6 people work with me, but we've also got in each county and each ICS effectively have a network. So Hampshire, Sussex, Kent, Surrey, Frimley, and Bob. And so at that level, each network then we have priorities, but at each level we are mandated to engage and to deal with inequalities, etc. So helping them deal at that slightly more local level will be really helpful, and whatever you can do for us to help that would be wonderful. We can from the region, we can cascade down to our networks, etc., and then the networks can act. So there's a whole lot, and it doesn't just apply to COVID and stuff, but you also think about asthma and COPD. If you've got asthma and you're homeless, your provision of care and your risk is absolutely huge. We know that, and then we've talked about tuberculosis, which in itself is still a problem, and also COPD. So these are things, as well as ordinary other things with lung cancer, etc. As populations get older. But absolutely, if we can engage and use COVID and vaccination as a way of getting in with respiratory health, I'd be delighted.
I think so would we, Richard. So would we. And we do have quite a big network now. Not everybody can come to every call, but we do have a big network, and we do have main contacts with the ICSs, and I believe there's health inequalities leads in each ICS, which we can just plug it with them as well. So Sally, you've got your hand up.
Good morning, everyone. This is my first time coming to this meeting, so apologies, I probably don't know everybody. So I'm the Drug and Alcohol Commissioner in Reading, and we've obviously been trying to get this population vaccinated, and we've had the vaccine bus come out to numerous homeless accommodations, and we've also tried to get it in our drug and alcohol service. And when you give this cohort a time slot to attend and have the vaccine, it just doesn't work. So I just wanted to share really that we've asked our CCG colleagues whether or not our nurses, our drug and alcohol nurses, and our outreach team can have that vaccine and administer it when we're interacting with these people, because it does go back to that every contact counts. And we have also been finding that this population has been a bit resistant to have the vaccine, because they kind of say, do you know what, I've been taking heroin for years, and how's COVID going to get me? So it does go back to that conversation where we're having with them every single day. And if we've got that vaccine on us and our nurses have got them in their hands, then let's do it there and then. And I think that will also help with that second uptake, because we're also finding that if we do get somebody jabbed the first time round, then trying to get hold of them to get their second one has been a bit of a challenge. So if we could get it in our drug service, then I'm sure the other drug services can help. And we do health checks and we do the flu jab as well, so it makes sense to kind of give us the COVID vaccine. So if we can push that in any way, we will.
Yeah, and I will push it too, Sally. So I think that's really good suggestion, and anything you learn from any best practice you can share would be gratefully received. So thank you. Sharon's offered to link in with you, Hampshire and Isle of Wight, Richard. So
perfect.
That's
I was
good
just
news.
emailing her back. Send me an email. Perfect.
Yeah, great. So no, we'd like to sort of build links with the respiratory networks. It's fair to say.
Yeah, I think that's the way forward, and that's the way for delivery, because you've then got engagement, as Sally was just kind of saying, with your local services, with the people doing the work on the ground, including, for example, we're beginning to roll out Hampshire Isle of Wight a whole bunch of diagnostic buses. So, again, there's no reason why these diagnostic buses went around couldn't necessarily do all sorts of other things as well. And the ICS, I really hope that the integrated care system approach really breaks down these boundaries and enables people to really practice to the limit of their ability and what they want to do. Because I think we need to do that, and I think that'll be so freeing and so wonderful to do it. Obviously, it has to be done right. Obviously, it has to be recorded right, and I can understand. I can see the administrative problems perhaps with it, Sally. But actually, have you had one? Have you had two? What did you have first time? Have you got your card? Of course, you haven't got your card, etc. But it can be done. It can be done.
Thank you, Richard. We've got a question from Nick.
Thanks, Debbie. Assuming that's me rather than the other Nick.
Yes, Nick Maguire.
Cheers, thanks. Just sort of a comment, and it's the same point I always raise, and it's about the collaboration between the health services and the non-stat outreach services, who are incredibly effective at knowing the people on the street and knowing where they are and knowing who they are and the biographical information about them. So we've just and pertains to all things, including respiratory problems. When you can get a nurse who has an understanding of what they're looking at, with going out with people who understand the biographical information of the people on the street, you get a great kind of team. And so, the nursing staff don't have the time to go out and find people, but when they work very closely with particularly our HVAS team, the Home Adult Support team, you get a really, really good set of teamwork there. And that's how that's how they're found. And that's how I think we catch people early with, high mortality of respiratory problems.
Yeah.
Are there any further questions? Any further questions from anybody? Or was it leave? So thank you so much, Richard. I think
a real pleasure.
That was a great conversation.
No, cool. And anytime, please, engage with Anne and the team, and we've already. I'm going to hook up with Sharon. That's great, fantastic, and other stuff going on. So as things develop, we should very much keep you in line, because for respiratory disease, as you mentioned, respiratory disease is after mental illness, the number one thing that goes on in the homeless population, actually.
Thank you. Thanks very much.